in Austria, and he will be proposing that our preferred target is 33 degrees. And then it will be followed by Hans Freeberg, who is from Lund in Sweden, and he will be proposing the preferred target temperature is 36 degrees centigrade. Just before we start those presentations, what we would like to do is take a poll, and there should be a simple questions that you can see on the screen for you to answer. And if I could just ask you to select your preferred answer to that question now, and then I propose we repeat the poll at the end of the webinar. So you can just do that now. And we'll give you a few seconds to complete that. Just as you're doing that, I should also say that there is the opportunity for you to ask questions using the chat facility of the webinar. And what I'll probably do is leave most of the questions for at the end of the two presentations. Okay, so I think it looks like this is going to be an interesting debate, because I can tell you the results as the poll has just closed now. We have 41% for 33 degrees, 52% voting for 36 degrees, and 7% for fever control only. So, Michael, you have the task really to try and turn that result around.
Yeah, I will try that.
Hand over to you, Michael.
Thank you very much, Jerry. Welcome also from my side. My task is to show you a little bit on why we should use a target temperature of 33 degrees, and I'm convinced that we should use a target temperature of 33 degrees. As you can see, my conflicts of interests with companies, there's also a scientific conflict of interest regarding therapeutic hypothermia, because I was involved in the preparation and performance of the HACCP trial, so I'm really into the 33 degrees part of therapeutic hypothermia. I just want to present, and first thing, a typical case of cardiac arrest to get you a little bit into the topic. This was a 71-year-old male with a history of cardiomyopathy. He had bypass surgery and a pacemaker. This guy collapsed in a restaurant, and there was no basic life support done. This patient was just put in recovery position. And EMS arrived after 10 minutes, and the first recorded rhythm was, fortunately, was a ventricular fibrillation, and the patient was resuscitated for 30 minutes. When he was admitted to our department, his lactate was 7.9 millimoles per liter. He got hypothermia with 33 degrees for 24 hours and was then slowly rewarmed again to 36 and had then fever control for the next 32 hours. He got some inotropic support, and he had elevated cardiac enzymes. And since he had a cardiac cause of cardiac arrest, we did also an angiogram, but he had an open bypass and no PTCA was performed. This patient woke up after 4 days, and he was solving crosswords after 1 week. So it was a very lucky case. And in our database, when we look at patients with ventricular fibrillation, about 60% of all admitted patients with VF have a similar cause with waking up after the treatment. So what we are treating here is the post-cardiac arrest syndrome. This is one is a multifactorial disease with the underlying cause of cardiac arrest, like acute myocardial infarction, as we have seen in the case. We have this ischemia reperfusion syndrome, and that leads to secondary ischemic damages, especially during reperfusion. We have some systemic inflammatory response, sepsis-like syndrome, and then we have also myocardial dysfunction that leads to the severe reperfusion syndrome with hemodynamic instability that we see in patients after cardiac arrest. And if we use a therapy like therapeutic hypothermia, we have a lot of systems where this treatment is influencing in. So that's just a simplified scheme of the mechanisms of cerebral ischemia. And a very similar scheme would be also for myocardial ischemia, myocardial dysfunction. And we have several different pathways that are involved in this cerebral ischemia. And what the fortune is that therapeutic hypothermia and cooling down to low degrees is that several of, or not all of these processes are positively influenced by hypothermia. So I will start with this slide here because we had a lot of discussion after the publication of the TTM trial in 2013, because everybody looked at this big study where there was no effect between hypothermia and 36 degrees, and I will come to that later on. And I want just to highlight that evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. And I will show you a little bit on the evidence that we have gathered so far. First of all, we started with animal studies, and that's just a summary of several animal studies between 1919 and 2014. There were mice and rats used, there were dogs used, pigs used, and rabbits, and there were several studies done from 1919 to 2014, and all of them did show a beneficial effect of 32 to 34 degrees versus normothermia, and was not showing an effect if the animals were not cooled. Very similar things have been seen then in human retrospective data. From 2006 on, there have been a lot of retrospective studies, and in all of these retrospective studies, the odds ratio in favor of lower temperature or cooling to 33 degrees was between 1.3 and 3.4. Although there in some subgroups there was no significant effect, especially in patients with in-hospital arrest or assisted. And when you summarize up the randomized trials of hypothermia after cardiac arrest, and that's a publication that was just published last year, systematic review of the Cochrane database. I will guide a little bit through this slide here. It was investigating neurologic outcome, and it was either conventional cooling versus no cooling, or conventional cooling versus 36 degrees temperature management. And that's a little bit of problem because to combine these two things, because here you have no cooling at all, and here you have an active therapy at 36 degrees. So, but we did combine that as a sort of sensitivity analysis. And if you combine those two data sets, either with versus no cooling or versus 36 degrees, you still end up with a positive effect for hypothermia with a risk ratio of 1.53, which would be significant and would lead to a number needed to treat of about 15 patients that you have to cool to get one additional patient with good neurologic outcome. If you do the same for survival, then you could only find an effect here in this group with conventional cooling versus no cooling. And if you combine then the other part of cooling versus 36 degrees, then this effect is diminished, and that's just on the edge to significance. Is therapeutic hypothermia or targeted temperature management a dangerous therapy? I don't think so. That's very dangerous. We have some side effects, and that's an part of the publication of Niklas Nielsen and the randomized trial of TTM comparing 33 to 36 degrees, and they found a little bit more intracranial bleeding, interestingly, in the 36 degree group. They found some bleeding on the insertion side in the hypothermia group, and they found some pneumonia and hypokalemia in the hypothermic group, but overall, there was not an increased side effect or adverse event rate comparing 33 degrees to 36 degrees. Although there are some side effects that we have to look at, there is no really significant difference between those two groups. And if you do the same for the groups between normothermia and 33 degrees, then we found only that pneumonia did make an effect here in adverse events. There was a higher rate of pneumonia in the cooled group, and there was also a higher rate of hyperkalemia in the cooled group compared to normothermia. There was also a systematic review of adverse events done already in 2013, and in this publication they concluded that most complications were preventable, like hyperkalemia. You just have to measure it and then you have to just give some potassium, and that they are counteracted by appropriate supportive care or intensive care, so serious complications are rare in this population. The problem was then when the TTM trial was published that publications like this were produced, where you could read that inducing hypothermia after out-of-hospital cardiac arrest, that latest large trials provide no support for these interventions. And there was a big misunderstanding that hypothermia didn't work at all, because in the TTM trial, there was a comparison between two different temperature levels, and I will show later on a temperature curve to show that a little bit better. But 36 degrees is an active therapy, and it's not normothermia. So here you can see this slide with the temperatures. That was the temperature curves of the TTM trial in the cooled group, and that was the control group here. And if you overlay this temperature curves with the normal temperature curves that occurs in patients after cardiac arrest, that taken from this publication here from Andrea Zeiner, then you can see that normally these patients have about 33 or 33.5 degrees over the time after the cardiac arrest. And you can see the difference here between 33 and 36 degrees. And it clearly shows that 36 is an active therapy. And the possible consequences that can occur if you treat patients with 36 degrees were published in this abstract. Unfortunately, there's no publication yet out of this, where they treated 70 patients with ventricular fibrillation and found that the compliance with the TTM therapy was worse in the 36 target period. They compared 33-degree period with the 36-degree period. And 50% of patients had temperatures over 33.1 in the first 24 hours when they were treated with 36 degrees. And what they found also was that the higher temperature, mainly a higher temperature than 37.1 in the first 24 hours, was associated with hypoxic brain injury. So it's not easy maybe to keep a patient at 36 degrees. And if you get a little bit higher with the temperature, it might be harmful. So I want to say a few words to the publication of Niklas Nilsson, and why I think that this study maybe didn't show really what's happening in those patients. They did a target temperature treatment and had two temperature levels, 33 degrees and 36 degrees. And what they found was that there were no significant difference in outcomes, either CPC scores or modified ranking scores. And the intention of the TTM trial was that there was missing evidence that the cooling patients after cardiac arrest was not working. So they concluded that there was lack of explanatory data, so they decided to perform this trial there. They included all patients. They had no definition or no clear definition of sedation, analgesia, and paralysis. They had no definition or exact definition of the cooling methods or the cooling goals that they want to achieve in this trial. And they had no information on the time interval from WASC to start of cooling. So if you summarize that together, then they didn't perform an explanatory trial, but they rather performed a pragmatic trial. And that's the problem with the TTM trial. And I want to explain it a little bit more, further detail. You have either an effectiveness or a pragmatic trial that looks at how well an established treatment works in practice. Or you have an explanatory trial that really looks at if a treatment would work at all. And you can measure the effect or the design of a treatment with this pragmatic explanatory continuum indicator summary, and have several factors that you are calculating here. And if the area is very large, then you can decide that this trial is a pragmatic trial, and if it's very small, then it's rather an explanatory trial. And the problem with pragmatic trials is if you have no difference in the outcomes in such a trial, then it's not suitable to provide explanatory evidence. So if you don't find a difference, you can't tell if this missing difference is due to the real world or to having really no effect. And the problem was also that in this TTM trial that the control group was very different to the other trials that have been performed before, maybe due to the 36 active therapy in the control group. If you compare it, for example, to the HACCR trial, with about 40% good neurologic outcome in the HACCR trial, with not cooling the patient, we had about 50% in the TTM trial, and the difference is much higher, for example, in the Stephen Bernard trial. And we had differences also in the exclusion criteria when we compared the HACCR trial and the TTM trial. So it was much more defined population here in the HACCR trial than it was in the TTM trial. And that leads to this pragmatic trial design of the TTM trial that I already tried to explain. And when you looked at the differences in baseline, there's also some differences that might influence the outcome of such a study. In the HACCR trial, we had very low rates of basic life support, which was much higher in the TTM trial. And what we also had, of course, then was very short no-flow times in the TTM trial compared to the HACCR trial. And patients in the HACCR trial maybe have been more ill, they had higher lactate levels, and the pupils were not so reactive then compared to the TTM trial. And when you looked at the intervention, the target body temperature, there was no real definition when they started cooling, but it was a maximum allowed of 4 hours until randomization. And then it took 6.5 hours until they had the target temperature reached. So 10 hours until they reached target temperature. In the study of Stephen Bernard, they already started rewarming here again. And if you really want to do a cooling study, then you might use a cooling curve like this with a clear and effective cooling device where you really can set the temperature to the desired level that you want to have. And if you looked at the no-flow times, and we did that in a retrospective analysis, then we found that the beneficial effect of therapeutic hypothermia increased with the cumulative time of complete circulatory standstill. So the longer the standstill, the higher the effect of hypothermia. And if you have very short no-flow times, like it was in the TTM trial, then there was no difference here between the two groups. So maybe this very short no-flow time in the TTM trial has, in part at least, led to the lack of differences between the two groups. And the last thing that I don't really understand in the TTM trial was the inclusion of the patients. Here you can see the centers of this trial, a lot of centers in Europe and some centers in Australia. During the time of 27 months, they screened 1,400 patients, which is about 1.5 patients per month per center screened, and then they included 1 patient per month. If I compared it, for example, to our number of cardiac arrest patients, we have about 150 comatose cardiac arrest patients a year, so it's more than 10 patients that we would screen for such a study. So I'm not really understanding this very low screening rates here. And there might be some sort of selection bias in these centers, but we have no information on that. So I conclude that we should use a target temperature of 33, and we should avoid using 36 degrees. And the reason is that all available evidence put together shows a beneficial effect of 32 to 34 degrees. The adverse effect rate is not increased with lower temperatures. Most of the adverse effects can be controlled with appropriate ICU treatment. And when we use 33 degrees, we can avoid temperatures above 33 degrees very easily. Thank you.
Michael, thank you very much indeed for that really nice, concise presentation in favour of 33 degrees being the preferred target temperature. Just before we transition to the next set of slides for Hans, I think I omitted to declare any of my potential conflicts of interest. It's important that I do that because I have not got a slide to show the audience. So I think the important potential COI for me is that I'm editor-in-chief of the journal Resuscitation. I've also been one of the co-authors for the European Society of Intensive Care Medicine and European Resuscitation Council guidelines on post-resuscitation care. So it's probably important to make those facts to you now. I should also say, Michael, just as a point of interest for the audience, I think you referred to a paper, or an abstract rather, from Janet Bray from Australia, with reference to their changing outcomes when they've moved from 33 to 36 in Australia. I can tell the audience, if they want to, that the accepted manuscript is now online in the journal Resuscitation, so that can be done. The full manuscript for that paper can be done.
Okay, I looked at the manuscript 2 days ago. It wasn't online yet, so.
Yeah. I think I just saw it. That's why I just checked just now as we were presenting. So, that's why partly I've declared my COI as the editor-in-chief, because I obviously had inside information that was just gone up there. So if I can ask the audience to, by all means, you can type some questions in now, because I think the questions that I will see coming up my screen will obviously be held over. But certainly, as we get to the end of Hans Freeberg's presentation, certainly go ahead and type some of those questions in, and I will pick those up and give those to the two presenters. If not, I have some of my own, of course. So, Hans, I think we're ready for you to go for a target temperature of 36.
Yes, thank you very much, Jerry. Hello, Michael. Welcome, everyone. Yes, it's my pleasure to be here and discuss and suggest the target of 36. And these are my disclosures. I also have the scientific disclosure, being the senior author of the TTM-trial. So I think it's worth mentioning a bit about the background, the important background, and the concept of intra versus post-ischemic hypothermia. Now, and these are data from animal experiments, mainly rodents, and there's really no question that intra-ischemic hypothermia does work. It does protect from brain injury in animals and in humans, although we don't have a randomized trial for that, of course, but many case reports. So that is not questioned by anyone. However, when it comes to post-ischemic hypothermia, I would put a big question mark here. Most trials or most studies, most animal studies, are done in rodents, and few studies, if any, in adult animals have shown a neuroprotective effect of post-ischemic hypothermia. We actually initiated a study in collaboration with a group in Edinburgh, Professor MacLeod, and the Camerates experience. We used their infrastructure and protocol to design a protocol for meta-analysis of temperature reduction in animal models of cardiac arrest. This protocol article is published, and we have some data, it's not published though, on the results of the meta-analysis that is still ongoing. But I can tell you that the preliminary conclusion from this meta-analysis is that the evidence for a neuroprotective effect of post-ischemic hypothermia in adult animals larger than rodents is sparse. There is actually very little data supporting that. So we move on to look at the concept of post-ischemic hypothermia in different target populations in humans. And it's relevant, I think, to discuss neonates, children and adults separately. First, when it comes to neonates and asphyxia, there have been several well-performed randomized controlled trials, and I think there is a good consensus that the evidence in support of post-ischemic hypothermia, therapeutic hypothermia after asphyxia in at least a subgroup of asphyctic neonates, that there is good evidence for that, and that hypothermia is beneficial. And this is also the conclusion in a Cochrane review. But the concept of TTM at 36, that is avoiding fever, has not been tested, and I don't know if it ever will. Let's move on to children, and I think those of you who listen are probably aware of the THAPCA out-of-hospital cardiac arrest trial that was published in 2015. These were children, median age of 2 years, rather special patient characteristics in this cohort of out-of-hospital cardiac arrest children. Large number of comorbidity, a lot of unwitnessed arrests, 60% asystole, low survival rates, rather low survival rates, and quite few patients actually that could be assessed for the primary outcome that was a measure of neurological function at 12 months. There was a signal in favor of 33 degrees Celsius as compared to the control arm, the control temperature at 36.8 degrees, with a relative likelihood in favor of 33 of 1.54, but with a non-significant p-value of 0.14, but definitely a signal. Now, just recently, this trial was published from the same group, and this was performed in parallel with the out-of-hospital cardiac arrest trial. This now is in-hospital cardiac arrest patients, a very different group a very different cohort of children. Median age was 1 year and different in many respects. Rhythm, witnessed, time to ROSC, time to CPR, etc. This was a neutral study. It was actually stopped due to futility. There were no differences in the primary outcome that was neurological, a measure of neurological function, and really no signal, no differences in the secondary outcome that was survival that is shown in this Kaplan-Meier curve. So no differences between 33 and 36.8. Actually, that Kaplan-Meier looks very similar to the Kaplan-Meier curve from the TTM trial, where we included and randomized 939 patients and randomized to 33 or 36 degrees. No differences in mortality, which was the primary outcome. With a hazard ratio of death of 1.06 for 33. And again, this was published in this journal some time ago now. And looking at the subgroups, these were predefined subgroups in the TTM trial: age, gender, downtime, that is ROSC, time to ROSC, rhythm, shock, and sight. And as you can see in this forest plot, really the results were quite consistent in all 6 predefined subgroups. And if anything, as you can see, the point estimates were actually all in favor of 36. Except you see one red dot to the left of the vertical bar, and that is for those patients with shorter times to ROSC, less than 25 minutes, which is quite the contrary to what you would have expected. I will come back to that. So if you summarize these 3 trials, the 2 first trials on which the guidelines were based in 2010, the HACA trial and the Bernard trials, two trials performed in the 1990s. And now this is a subgroup, the 80% of the patients in the TTM trial with the shockable rhythms. And what you see here is survival. The red bars, no cooling in Haka and Bernard trial, while controlled temperature in the TTM trial. And very, very clear that the difference is within the control arms. If you avoid fever, as we did, you get the same results as in the 33 arm in the TTM and in the Haka trial, approximately 60% survival rate. Neurological outcome was performed in the TTM trial from 4 different perspectives. From the clinician perspective, the patient perspective, the observer perspective, and we also looked at performance outcome. So rather extensive reporting of neurological outcome of survivors, and absolutely no differences in any of these tests between 33 and 36. So what about the subgroups? Have we so far identified a signal in any of the subgroups? For example, do frail patients benefit from 36? I chose this question, and that is because, yes, maybe. We may have found a signal in the frail patients. And what are the frail patients? Here are some examples. One group of frail patients, and this will be, of course, studied in the upcoming TTM-2 trial. One such cohort is those patients with shock on admission, frail patients. Another is those with longer no-flow times. They may do worse with a more invasive intervention of lowering temperature to 33. And a third group of patients with a lot of comorbidity would be the in-hospital cardiac arrest patients. So first, here's the patient subgroup with shock on admission, approximately 140 patients. And as you can see, there was a difference, although not statistically significant, with patients randomized to 33 having a worse outcome. And if you looked at ICU mortality, it was 66 versus 44%, with a p-value of 0.06, a clear signal that patients in shock or light shock do worse if they are treated at 33 degrees. What about no-flow times? Well, Michael showed you some data on a registry study they performed. This is prospectively collected data from the TTM trial, probability of death here on the y-axis and incremental increases in no-flow times on the x-axis of 2 minutes. With regards to probability of death, no differences, no signals in the 2 intervention arms. But when you look at the probability of poor neurological outcome, quite unexpectedly, patients treated at 33, it looks as if they do worse with a longer no-flow times, and possibly somewhat better in the shorter no-flow times. This may be a random finding, but it also may be, it's a signal that we want to follow up on in the TTM-2 trial. So quite the contrary and quite the opposite to what Michael showed. This is based on 250 patients that did not receive any bystander CPR, by the way. Lastly, in-hospital cardiac arrest patients. This is a study from the Get With the Guidelines resuscitation investigators in the US. And what they concluded from this registry study was that the use of therapeutic hypothermia compared with usual care was actually associated with a lower likelihood of survival. What do the guidelines say? Well, the 2015 guidelines state, and this is the main finding, it should have been on top. It says TTM is recommended for adults after out-of-hospital cardiac arrest with an initial shockable rhythm who remain unresponsive after ROSC. Strong recommendation with a low quality of evidence. This is important, a low quality of evidence. And this is actually identical to what we concluded in our meta-analysis in 2010, contrary to the Cochrane reviews performed by the Austrian group. Second, the guidelines recommend that a constant target temperature between 32 and 36 for those patients in whom temperature control is used. And this is solely based on the results from the TTM trial. They say strong recommendation with a moderate quality of evidence based on the TTM trial. And lastly, for the other rhythms and for the in-hospital cardiac arrest patients, there is a weak recommendation with a very low quality of evidence. So in conclusion, with regards to TTM and the 2015 guidelines, we have low to very low level of evidence data supporting the use of induced hypothermia after cardiac arrest. And we have moderate level of evidence that it does not really matter what temperature to target in the 32 to 36 degrees Celsius range. There are recommendations, and my recommendations are that we should adhere to the guidelines. One thing that I did not mention previously, and that I think is quite important, is that in the TTM trial, this is actually a trial where we control temperature for 72 hours after cardiac arrest. We included patients and randomized to 33 or 36, and after the intervention period, after the rewarming at 36 hours, we continued to control temperature in both intervention arms for another 36 hours. So this is the TTM concept that we use today. I also think that the results from the TTM trial should make all of us think that we need to think outside of the box, and we should be ready to expect the unexpected. We should pay attention to excellence in ICU care. For example, cardiac intervention when deemed necessary. We should control temperature at 36, less invasive. We should avoid post-intervention fever, and we need to improve our prognostication protocols. This was done in the TTM trial. This was not done in previous trials. Not controlling prognostication induces a lot of bias. And very importantly, we should not stop treatment too early. Prolong care if you are unsure about the patient. So the rationale and the arguments to use a target of 36 is that there is no difference in outcomes between 33 and 36, and that point estimates actually indicate benefit of 36, and that there are some subgroups that we have identified that signal a benefit of 36, frail patients, those in shock, those with long no-flow times, and possibly in-hospital cardiac arrest patients. 36 is closer to normal. It reduces risks, known and unknown risks. For example, that of drug dosing. No drugs have been investigated at 33. Electrolytes and infections. It's also less invasive. And actually what we do is that we keep the patient at the admission temperature. These patients come to the hospital at somewhere between 35 and 36. Just keep them there. Thank you.
Hans, thank you very much indeed for that excellent presentation in favour of 36. So we've now heard presentations supporting both 33 and 36. So I invite the audience to send any questions. I've got at least one question to put to our two speakers at the moment, which I'll do in a moment. But anything else, please send it through, and we'll try and address that in the 20 minutes that we have available. So Hans and Michael, the first question that we've got from one of the attendees concerns children. And I'll perhaps put this to Hans first, because you were the one that mentioned the two FATCA trials, both the out-of-hospital and the in-hospital trial. And the question really is what perhaps should we be doing with these children? Because the point that's been made by the person asking the question is that the children are not just small adults, they're different. should we be dealing with them any differently based on the data we have so far?
I have personally very little experience with children, so the only thing I can lean upon is the results from the two trials. The out-of-hospital cardiac arrest trial in children, where there was a very clear signal that in favor of 33 as compared to 36.8. Truly, I don't know what to recommend. I should definitely control fever in these patients if I had one. I'm not sure I would go for 33. I would probably keep the patient in the 36 to 36.8 degree level.
Okay, and Michael, I don't know whether you deal with children in your practice.
No,
but any...
Sorry, we are not treating children, but I was just wanted to do a remark on that hypothermia is currently used in neonates with neonatal ischemia or hypoxia, and this is used very fortunate in this patient population. But the problem with children is that they are very different to the adult population regarding cardiac arrests, because they have other causes of cardiac arrest. Most of the causes here are hypoxia. So maybe the damage that already happened with hypoxia is so severe that you have to have that the effect of hypothermia is diminished, and that we have found a signal in this study, and maybe the number of patients included in the study was too small to show them a beneficial effect. So you really have to consider the different causes of cardiac arrest maybe, and then in adult cardiac arrest situations, you also see some difference between patients with ventricular fibrillation and with hypoxia or pulseless electrical activity or asystole, where the effect of hypothermia is diminished in those other cases.
Thanks, Michael. I took the opportunity when I saw that question come in of just scanning the 2015 ERC guidelines for pediatric resuscitation. At the moment, I think the main message there, and we must remember they did have the results of the out-of-hospital FAPCA trial, and their conclusion for the guidelines there was to at least avoid hyperthermia. But they didn't really go into specify any specific target temperatures other than that. And I suspect that the results of the in-hospital study will not change that, but I will obviously have to wait and see what my pediatric colleagues, because I too, like the two speakers, don't really deal with many children. We've had, thank you for the questions that have come in now, and I'll try and deal with these because I want to make sure that you as the audience get an opportunity to get your questions answered. So I think a good question, this one. We've discussed 33 and 36. The obvious question is, what about something in between? Why not 34 or why not 35? Michael, do you want to take that one first?
Yeah, we actually don't really know what is the exact target temperature. We know that there is some effect maybe between 37 and 36, according to this abstract presentation of when you not adhere to 36, when you have then higher temperatures of 37, that you have worse outcome. So there is some hint that there is a difference between 37 and 36 degrees. And then we have studies showing differences between 37 degrees and 33 degrees showing an effect, and no effect between 36 and 33 degrees. So we don't really know what will be the best temperature in treating patients after cardiac arrest. So it might be somewhat reasonable to use a temperature just in between those two temperatures, but we have no studies on that. But as I already mentioned, to be a little bit on the safer side, you should maybe adhere a little bit to the lower temperatures, that you avoid really getting above 37 degrees or in the nearby 37 degrees, where you maybe then get a worse outcome.
Okay, thanks, Michael. And Hans, your response to that?
Yes, well, my response is why not? Or rather, it probably doesn't matter. I'm more keen on trying to find out whether the concept works or not. And in doing so, we need to improve the evidence with regards to animal studies. The quality is not as good as you think, and the evidence is not at all as good as most people believe. There is plenty more to do, and this is really a decision we made after the neutral result of the TTM trial. What we have to do now is go back to the animal lab and really perform the correct trials. And before we go back to the animal lab to do that, we need to actually evaluate the evidence there is. And as I mentioned, we have only preliminary data, but you will be surprised. The evidence is not good.
Okay, thanks, Hans. Just as a follow-up to those two answers in response to the question about a temperature in between 33 and 36, I should remind everybody that, of course, the current guidelines are for a constant temperature somewhere between 32 and 36. So strictly speaking, one can select 34 or 35, for example, and still be within those guidelines. Okay, let's take the next questions. We've got 2 or 3 other questions to come in now. What about specific populations? And a question that's been asked, and this is, I think, a good one that often gets asked, is what about patients who have come in with essentially primary hypothermic cardiac arrest? So perhaps they've been involved in drowning, for example, and they come in very cold to start with. How is the best way of dealing with those? Again, Michael, do you want to take that first?
Yeah. The problem with that population is that we don't have any studies showing really dealing with the type of patients. With hypothermic patients after cardiac arrest, we have to aim that we get at least a temperature above 30 degrees so that we can resuscitate those patients. And so that the temperature in hypothermic patients in cardiac arrest should be increased rather rapidly to a temperature where we can resuscitate those patients. And then after we have return of spontaneous circulation, I think there should be some sort of hypothermia treatment in those patients. The question is if you rewarm those patients from very low temperatures to 36 degrees, for example, that you maybe then do some harm due to the rewarming effect in those patients. So I would suggest for those patients with hypothermic cardiac arrest that you stick to maybe lower temperatures in the range between 32 and 34 degrees, which was also some sort of recommendation in the guidelines of drowning that were published just, I think, 2 years ago. So.
Thanks, Michael. And what about you, Hans? Any views on the hypothermic cardiac arrest?
Well, yes, I agree with Michael that you need to rewarm rather rapidly, up to above 30 at least, and then a slow rewarming. I would rewarm slowly up to 36 and keep the patient at 36 and avoid fever for the next 72 hours.
Okay. All right, well, let's move on to another question. We might come back to rewarming a little bit in a moment. There's a question here, and I think this is also one that I've heard asked quite a lot since the TTM trial. If your choice is to choose 36, and I'll put this question to Hans because it's obviously directly relevant to you, is it still reasonable to use intravascular cooling systems, or do you tend to avoid those if your target temperature is 36?
No, we don't. We just published a paper where we presented data on surface cooling versus intravascular cooling. It's quite clear that if you believe in precise cooling, the intravascular device performs better. While when you look at the outcome data, it does not seem to matter. So, and we use both. We use IV cooling and we use surface cooling. And this is the reason, one reason is that we need to keep up the competence to use both. So we are, that's the main reason why we want to continue using both.
Okay, and you're just to clarify, are you using some sort of feedback control systems on both your intravascular and surface systems?
Yes, we do. We do use feedback control for both systems. Yes.
And in fact, Michael, can I ask you what techniques you're using for your targeted temperature management when you're using 33?
So we are using both surface cooling and endovascular devices. And we're using also feedback controlled and not feedback controlled devices also to get some sort of competence with the several different systems. It's not so important that which system you're using. It's important that you adhere to the temperature. And it's much easier if you have an endovascular device because you type in the temperature and then normally this device holds this temperature very precisely. And if you're using surface cooling devices without feedback control, then you have to have some sort of nurse control implemented, that you really look at the temperatures, have your monitor alarms set to the appropriate temperatures, that you avoid getting out of your temperature range.
Okay, and I'll link to, we've got quite a few, well, 2 or 3 other questions here. I'll try and cover these. So linked to this, that we have an attendee that's asked about the new esophageal cooling device, which I think there has been a few preliminary reports on that. Do either of you have any experience with esophageal cooling? Perhaps Michael?
I don't.
Oh, sorry.
Yes. Sorry, I do not have any experience, unfortunately. Do you, Michael?
Well, I've just seen the device. But we didn't try it in our hospital. But from the data that was presented by the company, it's comparable to other surface cooling devices with a cooling rate of about 1.5 degrees or so. But I don't have any personal experience on that.
Okay, and then we've got 2 questions, in fact, from the same individual. I'll link those because they're both practical questions. So aside from the hypothermic cardiac arrest that we discussed earlier on, what do you do about rewarming? How long do you take to rewarm? And I'll put that to Michael first, because I think if you're using 33, that's perhaps a more important question to ask.
So normally we are using a rewarming rate of between 0.2 and 0.4 degrees per hour, but at least below 0.5 degrees per hour, because in some retrospective analysis there have been shown some effect of the rewarming rate. And if you have a very high rewarming rate, then there might be some worse effect on the patient. So we try to really slowly rewarm the patients at rates about 0.3 degrees per hour.
And do you then set your target temperature at 37 until 72 hours after ROSC, or do you set it at 36.5, just below, to ensure absolute?
We set it to 36.5 degrees when we're using feedback devices. Okay,
so that's a useful practical tip. So you actually do set it slightly below normothermia, even during the latter part of that 72 hours.
And 36.5 is the low range of normothermia, if you have normothermia from 36.5 to 37.5.
Okay, thanks, Michael. The question that particularly interests me, because in fact we published some work on this, it relates to feeding. Perhaps Hans, I'll ask you this first. Do you feed your patients during the cooling phase?
Since we moved to 36, I mean, all these issues are really not issues anymore. We feed the patient as we do a regular ICU patient today. No restrictions.
Okay, and what about Michael? And of course the importance here is that at 33 degrees there may be some reduction in absorption of enteral feed, although I have to say I'm aware of very little data to necessarily support that.
We start feeding when the patient is rewarmed again at over 36 degrees.
So you are not feeding for the first 24, 36 hours then in that case?
That's correct.
Okay. What's the reason you don't?
We thought about that the metabolic rate of those patients will be very much reduced, so the demand of nutritions are rather low then. So, and then there is a lot of discussion if we really should immediately feed patients or not immediately feed patients. So the effect of immediately feed patients is not really totally established, and we thought that maybe there is some sort of overfeeding then if you or over demand feeding in patients that have low demand during 33 degrees.
Okay, thanks, Michael. And then I think there's time for at least one more of these questions. And I've saved this one back because this is perhaps slightly more complex. So the question is, in the different studies, was the time to target temperature, time to reach the goal temperature, were they roughly similar? And I guess presumably we're referring to perhaps the HACCR trial versus the TTM trial.
I can start.
Thanks.
Yes, is that okay? Yes?
Yes, of course.
Yes, I would like to correct Michael because I have actually the slide in front of me here. While it's not shown in the HACCR trial figure because the line is actually cut, but it is for the cooling rate and when you actually do reach the target temperature. But it is, I think it was a median of 8 hours or so in the HACCR trial. But you may please correct me if I'm wrong, Michael. But we do know the time to target below 34 in the TTM trial, and we had a median time to randomization of 130 minutes and a median time to reach below 34 degrees of 150 minutes. So time to target below 34 degrees was 280 minutes, 4.5 hours, not 10 hours. So this is some misconception that those opposed to the TTM trial very unluckily tend to repeat. And I would like to ask Michael not to use the 10-hour reference.
You didn't publish it, so that's the problem.
Well, you've heard me say this several times.
Yeah, no, but not in the paper. That's true. But if you really do hypothermia studies, when we did the HACCR trial, we didn't have a different cooling device. We had a very slow cooling device, and so we just had to use that device that we had at that time. But if you are doing a cooling study now, then you should really use a cooling device that really helps you achieving your goals of cooling. So that's one problem of the trial, for example. So you really can exactly control temperature.
Thanks, Michael. I've just got a very quick question now to finish. What about those having a massive blood transfusion? So if you've got bleeding as a problem, I'll put this to Michael because the question is should we then be using a target temperature of 36 if there's a potential coagulation issue?
In those patients, we would use higher temperatures. So therefore, we would use 36 degrees in those patients if you have a bleeding problem, because hypothermia at 33 degrees has some influence on the coagulation system. So therefore, we would use higher temperatures then.
Okay, thanks very much, Michael. So can I ask the audience to please see if we can get our question to our poll answered again, because remember we were asking about these questions. If you could please put your preferred answer there, so 33, 36, or fever control only, and we'll see whether we've swung the audience or not. Give that just a few more seconds. Put your votes in now, just a few more seconds, they're coming in. It's very exciting. Okay, I think we've got enough there. I'll close it at that point. And then I'm going to see if I can share these results. Oh, there we go. You can. Hopefully everybody can see those results. So So if anything, I'll just remind you that the pre-poll we had 41% for 33 and 52% for 36. So I think if anything, it looks as if Hans has managed to shift a few more of the delegates towards the 36. So well done, Hans. Just remains for me to thank both our speakers for excellent presentation and discussion, Michael Holzer and Hans Freeberg. And I'd also like to thank Dominique de Bon for her administrative assistance and for instructing us on how we work this webinar. And thank you to you, the audience, for listening. I hope it's been of value to you all.